Hi, I'm Shane Blackmore and welcome to this video case presentation. I'm going to be presenting a patient of mine who tore the meniscus in her knee and then subsequently went on to have a meniscal repair. Just a few disclosures before we start. This presentation and the videos in it are really for patient education and not really for medical education. All the videos that you do see are videos that I've taken on patients that I've operated on, usually in my private practice. Just of note, I do have an agreement with Stryker and I'm involved in the teaching of robotic joint replacement surgery. A little bit about me. I went to school locally in Melbourne before attending the University of Melbourne, completing my medical degree. I then went on to train at the Austin Hospital before going on to take part in the Victorian Orthopaedic Training Program. After completing the Orthopaedic Training Program in Victoria, I headed overseas for subspecialty training. My first fellowship was in London, United Kingdom, with a focus on shoulder and elbow surgery. Following my time in the UK, I headed to New York City. I spent a year in New York City in an accredited fellowship in sports and arthroscopic surgery. Following my time in New York, I was then able to become a member of quite a number of sports and arthroscopy societies, international societies, but back home I now practice in East Melbourne with a number of colleagues. I work at multiple private hospitals around Melbourne and have a public appointment at the Austin Hospital where I'm the Director of Training. So moving on to the case that I want to talk about today, this is a young patient of mine. She's 18 years of age. She twisted her knee while playing netball, and luckily it was not her ACL she tore, but her meniscus. Unfortunately, she went on to have pain with a lot of her activities, and although pain was her main symptom, importantly not having any locking or giving way of the knee, it continued to trouble her and prevented her from playing her sport. Just a bit of background on the meniscus. We often hear that patients had their knee scraped and a bit of cartilage removed. There's really two types of cartilage in the knee. There's the shock-absorbing cartilages, which we call the menisci. We have a medial meniscus on the inside part of the knee. We also have a lateral meniscus, which is on the outside part of the knee. The other cartilage we see in the knee is a cartilage that lines the bones. This is hyaline cartilage, and when we lose this cartilage, we refer to that as arthritis. Often in young patients, they'll tear their meniscus, but their cartilage surface or hyaline cartilage will be intact. Most of my patients, either before seeing me or after seeing me, will go on to have an MRI of their knee. Here's a picture of an MRI. Sorry, we're just going to start that bit again, and we'll edit it out. So edit it out. Here are some arthroscopic photos of a patient's knee, both demonstrating tears of the menisci. These are quite significant tears of the meniscus. Most of my patients before seeing me or after seeing me at the very least will go on to have an MRI of the knee. Here's a couple of examples of MRIs of the knee. What you'll note on this front-on view here is that the meniscus is intact on one side, this black box area, and on the other side you can see this area of disruption. Here are some other views, the side-on view or a sagittal view we call it. You'll see that the meniscus is present here at the front of the knee but missing from the back. Here's another MRI, again very similar type changes. If I just highlight down the bottom here, you'll see that the meniscus is torn and disrupted. Here are some arthroscopic photos of a meniscal repair. It's quite obvious on the left photo that there's a tear of the meniscus, and then all of a sudden that tear comes together as we start to repair it. This is a side-to-side repair of a radial torn meniscus. We'll move on to the video now. We'll move on to the video now. So all arthroscopic repairs of the knee start with an arthroscopic assessment of the knee. Here you see me driving the camera around the knee, just looking at certain structures, looking for loose bodies, looking for damage to other structures that we're not expecting. Here I am in the patellofemoral joint, and you can see some strands of cartilage below the patella. We move into the medial side of the knee, or the medial compartment. At the top you'll see the femur that's got normal cartilage as we'd expect, and the tibia at the bottom, and in between is the meniscus. The meniscus looks relatively normal, but we bring a probe in through one of the other portals, and you can see now the probe falls into the torn area, and the tear itself shows that the meniscus is actually quite unstable. You could imagine through a range of motion that could be uncomfortable. Here's the ACL, we check the ACL's okay, and here's the lateral side of the knee, the lateral meniscus, again between the femur and the tibia, and we're just using the probe just to confirm there's no tears or disruption of the lateral meniscus. Finally, we're just checking the cartilage surfaces of the knee to make sure they're all normal. Here is a rasp. We're bringing in a rasp where the tear is now. We use this rasp just to clean up the edges of the meniscal tear. Often there'll be bits of fibrous tissue or other healing parts that we just want to remove so we can get back to a fresh bed for the repair. We bring an arthroscopic shaver in now very carefully, and we use that shaver in the tear just to remove any of this loose debris so we can start our repair. We're being very careful not to damage the cartilage surface of the knee. Here comes the first of the repair devices. You can see it's got quite a sharp tip on it. The sharp tip pierces the meniscus, and what we're looking to do is pierce each side of the meniscus. This goes into quite a controlled depth. We try to control where this goes because of structures out the back of the knee, nerves and blood vessels that we don't want to injure. Once this is pierced into the meniscus, it has a little anchor that's deployed. That anchor then fixes itself to the back of the knee, and then we deploy a second anchor. So you see this is passed a second time, deploying a second anchor, and this leaves a suture intact that goes across our tear. We bring in a second device. This is a knot pusher, so it's pushing down on the suture material. The suture material already has a pre-tied knot in it, and we're just tightening things down. Once we're happy with the tension, we cut the suture away. What you might notice here is now the meniscus is somewhat flipped up, so this will allow us to pass one of these devices underneath the meniscus. You also notice that the device has a plastic sheath on it. The plastic sheath is designed to help try to protect the cartilage surface of the knee. So as we're repairing this meniscus in what you can see is quite a confined space, we're trying to minimize the damage to other structures that are normal through the knee. Here we go again, just tightening up that pre-tied suture material, and this helps bring the meniscus back down into position. We're very careful with the tension here that we don't pull through the meniscus, and once we're happy, we cut the suture. So we're going to just complete this process a number of times. Obviously, the number of anchors we put in or sutures is dictated by the size of the repair. You'll notice that previously as I've passed sutures, I've passed them in an up and down or vertical type pattern. On this occasion, this is a bit of a side to side repair, so so-called horizontal repair. And we're using this horizontal repair because this really suits me here. I've decided that this is probably the best way to help reduce the meniscus in this position. Again, we tighten the sutures, again with pressure on the knot so that we don't pull the meniscus away or worsen the tear. Again, working underneath, you can just see the tear underneath where this instrument's going in. You may also note that the needles are quite curved. They're curved so we can rotate and use the needles to aim for exactly where we want to penetrate the tissue. We pass the second one again, and like we've done previously, we just pull down on the suture, again with pressure on the meniscus, and cut it away. We can start to see now the meniscus is starting to come together. I know from the probing earlier on, the meniscus is a little bit further around, or the tear is at least a bit further around, so I want to continue these sutures. And you can see at this stage that the suture material is coming in on the right of the screen and the camera is on the left. You'll see later that we swap this around. There are 2 incisions made at the front of the knee for most knee arthroscopies and most knee procedures. And through those two portals, we call them, we can put the camera in one and the working instruments in another, and obviously we can swap those over. And we may swap those over just to change the angle of trajectory so that we can complete the repair properly. So here we go. Looks like we've almost completed the repair. So if we think we're almost finished, we'll often bring a probe in. We bring the probe in just to check that the meniscus is stable, and here we go. We can see that there's a part of the meniscus we still haven't got. You can see the probe is coming in from the left of the screen now, so we've swapped our view, so we're now viewing on the right hand side and we're working from the left. And where this part of the tear is, it makes it easier for it to be repaired with this instrument coming across the knee rather than in line, which would have been quite difficult to get the sutures to properly traverse the area of the tear. Again, we place one over the top, tighten it down with our knot pusher, and once we're happy with the tension, that we've taken all the tension out of the suture, we'll gently push down with the knot cutter. There we go. And there we go with the probe again. We can just see changing our portal again. The probe's coming in from the right, but again we might need just one more suture underneath there just to cross that tear. Here it goes, puncturing underneath again Deploy the first anchor, come back out, and deploy the second anchor. All right, that should now complete our repair. You can see now the meniscus looks relatively normal. The last part of this operation is we want to try to aid in meniscal healing. So I'm just taking down some soft tissue in the notch of the femur. This gets us down to some bare bone. I use a bit of a curette here to scrape onto the bone. And then I use a punch. You see the sharp instrument coming in a moment. There it is. And we just knock that into the bone. So we're actually making holes in the bone. And you'll see what comes out in a moment as I pull this instrument back out. You're seeing little blobs. They look like oil in water. Those little blobs are marrow. So we're trying to get the marrow elements to come out of the bone. Those marrow elements contain a lot of healing factors, stem cells and the like. And we like to release these into the knee because there's some belief that by releasing these types of structures or types of substances into the knee, we may improve the healing of the meniscus. We finished the operation by just cleaning up the torn parts of the patella we identified earlier, as well as removing any loose debris in the knee. Thank you for watching my video in regards to meniscal repair. Hopefully it's answered some of your questions and shown you the surgical technique we use to repair a meniscus. Thank you for watching my video on meniscal repair. Hopefully it's answered some of your questions regarding meniscal repair and demonstrated to you how the meniscus is repaired surgically.